Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative. And for those of you who may not be familiar with the PCC, we are a membership organization that is comprised of 70 different members that really span the entire healthcare system. But what unites our members is a dedication to strengthening primary care as the foundation of every high-performing health system. For our May webinar, we are going to be focused on alternative payment models for primary care in the commercial sector. And I am pleased to introduce our moderator in just a moment. But first, a couple of housekeeping items. We'll have 10 minutes of Q&A at the end, but don't hesitate to put your questions in the chat as they occur to you over the course of the next hour. All of your lines are automatically muted because we have hundreds and hundreds of people on our broadcast today, and so that really is the best way to keep things organized. We are recording this and the webinar will be posted within 24 hours. So if any of your colleagues have missed this, you can send them a link. And we do ask you to fill out the survey at the end because we really want to get your feedback. Without further ado, let me introduce Molly Chichester. Molly is Executive Director and Deputy Director for Healthcare Innovation at Morgan Health. She supports efforts to advance affordability, quality, experience, and health equity for the 160 million Americans who receive their health insurance through an employer. In this role, she leads a team responsible for supporting Morgan Health's portfolio companies and helping to pilot healthcare innovations in the employer space. Before joining Morgan Health, Molly was an independent consultant, helping to grow and scale mission-driven organizations, including health tech startups, government programs, and community-based organizations. And prior to that, she was senior advisor to the New York State Medicaid Director and Chief Operating Officer to Stop the Spread, a COVID-19 response program under Impact Assets. She's also been Chief Strategy Officer for One City Health and Chief of Staff to the Chief Transformation Officer of New York City Health and Hospitals, the largest public health system in the United States. Please welcome Molly, who will be moderating today's session.
Hi, good afternoon. Thanks so much, Ann. Good afternoon, everyone. Thanks, Ann, for the nice introduction, and thanks so much to the Primary Care Collaborative for hosting this important discussion. And I want to start by talking about just that, why this discussion is so important. Today, the dominant form of payment for primary care remains fee-for-service, and it is no secret that the fees for the important work of primary care providers are low, and that has real consequences. For example, as a result, we see short visits that shortchange both patients and clinicians and undermine the effectiveness of the entire system. And while Medicare and Medicaid have deployed new models to change this paradigm, efforts among commercial payers and providers to move to alternative payment models that reward proactive population health activities, that support whole person care, and that optimize interdisciplinary teams have been slow to take hold. Today, we'll talk to three innovators who are doing the hard work of collaborating in the commercial market to design and implement alternative payment models to strengthen primary care teams. And we'll discuss how we can remove barriers and scale innovations. And before I introduce them, I just want to take a moment to share a little bit about Morgan Health and why this work is so important to us. Morgan Health is focused on improving the quality, equity, and affordability of healthcare for the over 160 million Americans who depend on employer-sponsored insurance, as Ann described. Our goal is to innovate and accelerate the adoption of new approaches to care delivery that advance this goal, with a focus on accountable care and value-based payment models. And we're doing this in a couple of ways. With $250 million from the JP Morgan Chase balance sheet, we're investing in promising companies, including primary care-focused companies. We have a team that's focused on policy reform to enable greater adoption of accountable care and whole person care strategies. And we're supporting and innovating around models that are designed to improve outcomes, lower cost, and advance health equity, including by offering new options to our own employees at JPMorgan Chase in partnership with our benefits organization. Just to let you know how serious we are about primary care, one of the first strategies that we pursued at Morgan Health was offering an advanced primary care model to our own JPMorgan Chase employees. We know primary care can improve outcomes and reduce unnecessary utilization, and yet by and large, primary care is underutilized, and we are looking to change that. And so I'm excited to be here to speak with others who are also committed to doing the same. So let me introduce you to our speakers without further ado. I'm going to start with Nate Murray, who is the Chief Business Development Officer for Crossover Health. Nate's an entrepreneur who is passionate about healthcare. He has worked on everything from product development and strategy for large payers to call center operations and health technology to building the largest online Medicare partner network through a direct-to-consumer marketing campaign. In his role today, Nate works closely with procurement and finance and benefits teams to design shared savings models that align incentives across partnerships to deliver demonstrable improvements along the cost, quality, and experience dimensions. That is not an easy job, Nate. We are excited to hear more about how you are doing this today. Welcome.
Hey, Molly. Thank you so much for that introduction. And Anne, thank you for what you do at the Primary Care Collaborative. This is really fun to be here and to have the other panelists join because, when I think about the Primary Care Collaborative and I join their sessions, they talk about a lot of really important things. Although it's been skinny on the commercial segment, it's been in areas of government-sponsored healthcare and Medicare and Medicaid, which are really important. But I'd love to see the love start to happen towards some of the commercial plans. And so today should be a rich discussion. Quickly, in the way of background, Crossover Health, we're a national primary care medical group, and we started back in 2010 in a little city called Aliso Viejo, California. We started as a direct primary care practice because we recognized that primary care, like Molly said, was so vitally important to our healthcare system, but we couldn't accept fee-for-service. We couldn't get into that financial arrangement that Molly shared, what really weakened the ability to deliver high-value care to members. And so we started DPC. It's a tough road. We quickly pivoted to start working with large self-funded employer and found a lot of great innovators among those self-funded companies that want to deliver a different benefit to their employees. And fortunately for us, we've been able to grow our company by partnering with these companies. The challenge is, as we see it, is that it leaves largely the payers out of it. And to touch a majority of the commercial membership, there's got to be a way for the payers to get involved, but it has to be in a mechanism and a payment mechanism different than fee-for-service. And so fortunately, I've been able to meet people like Anne, people like you, Molly, people like Rebecca and Nina that are thinking about these topics as well. And so I'm super excited to have this discussion about alternative payment models in the commercial segment.
Great. Thanks so much, Nate. Next, I want to introduce Dr. Nina Birnbaum, who is Medical Director for Innovation Acceleration at Blue Shield of California. And in addition to her role at Blue Shield, Nina serves her community as a family physician. She previously served as the Medical Director for Primary Care for a multi-specialty medical group in the Bay Area. Her work is focused on supporting high-functioning multidisciplinary teams and amplifying the joy of work in clinical practice. Welcome, Nina. It is so great to have a primary care physician on this panel, given our topic.
Thank you. Thanks for having me. I'm really honored to be here. And being at the payer, having come from the delivery system and now being at the payer for the last couple of years, I'm really excited about all the opportunities that we have to try to knit together pieces of the system that historically maybe haven't worked super efficiently together or have seen each other as adversaries, and start to realize that the problems that we are all facing, we're facing together. And so the more we can join together to figure out how to solve them, the more likely we are going to be to solve these complex problems that we're facing.
Thanks so much, Nina. And finally, I want to introduce our third panelist, Rebecca Weber, who is the Executive Director for Innovation Strategy and the commercial product at Aetna. In her role, Rebecca heads the disruptive innovation product team for Aetna's self and fully insured commercial business. She was previously a consultant for Clay Christensen's Insight and brings a background as a behavioral economics researcher at MIT to her work. I love that. Rebecca would love to see more behavioral economics intersecting with healthcare. And she focuses on addressing foundational affordability, access, and quality challenges by approaching them from new angles, such as alternative plan design and pricing models. Thanks for being here, Rebecca.
Thanks, Molly. I mean, this is just a great conversation, and bringing together payers and providers. I totally agree, Nina. I think that that's really critical here. In my role at Aetna, it is a lot of questions about, well, what's working really well with commercial insurance, and where are there problems with things like access and affordability, those basic sorts of things. And so I actually ended up coming to this world of primary care alternative payment models from the angle of, I started with the question looking at high deductible plan designs and looking at affordability and access issues that can arise when members, patients have deductibles. Are they utilizing care, as much as they should? And so the question was, how could we change the access and affordability angle for patients, for members, but keep the overall cost and cost profile of that insurance plan for members and for employers? And how do you do that? I mean, actuarially, that's not trivial. And so coming at it from the angle of, well, can we look at things like direct primary care models that don't have the infrastructure around billing, fee for service type billing, and how could we pair insurance with those sorts of models? So at Aetna, we actually are working with Nate from Crossover in doing just that and really integrating it into plan design to make that all work together.
Great. Well, as I'm sure our audience can tell, this is an impressive group of experts that we have today. And one thing that I found particularly interesting when I was learning about each of you and we were getting to know each other is that you all shared in your bios a love for the great outdoors. So before we jump in, I wanted to do a little quick icebreaker. Rebecca foraging mushrooms, Nate surfing, Nina spending time in the hills and the beaches of the Bay Area, which sounds lovely. Before we dig into some more of the content, this is totally unrehearsed, but would love to know your favorite outdoor vacation spot recommendations you have for folks.
That's a great question. I can start just because I've been thinking about it a little bit recently, but Whistler, Canada is a beautiful location, and specifically, I would argue for somebody to email me a prettier drive. And I grew up in the Bay Area, which is like just beautiful, but a prettier drive from Vancouver to Whistler, Canada. It is just the most gorgeous landscape I've ever seen in my life, and the lakes and the hills. I just think it's fabulous. So if you get a chance to go to Whistler, it's beautiful.
I had the opportunity to go to Lander, Wyoming a few years ago to drop my son off at a Knowles course. And wow, there was like these gazelles, I don't know what their actual name, but they look like antelope, like bounding around in the grass, and just the mountains and the rivers. And it was just incredibly beautiful. I would highly recommend it to anybody.
Gazelles. I'm going to make a plug for looking around your own area. That was how, during COVID, not traveling to work, I started taking walks around my neighborhood, and it turns out there's so much to see, and that's how I got into the foraging. And so that's my plug for just look around, walking distance, driving distance. Maybe there's gazelles. Maybe not, but something good.
Nate, I'll share. My husband reluctantly took me skiing a few years ago, right before COVID. but have totally converted. We spend a lot of time, not Whistler, but up in Vermont and the Catskills in New York, which is beautiful. All right, well, let's get into a little bit more about what brought this group together today. You shared a little bit of this in your opening remarks, but can you just spend another minute talking about to this group why your organization is really focused on strengthening primary care, and just share so that folks are familiar a little bit of the ways that you're doing that. And Nate, maybe we can start with you.
Yeah, so we're a primary care medical group. I mean, we actually read Innovator's Prescription. It's a Clayton Christensen book back and in maybe 2008, 2009. And my two partners, Dr. Richard Patrononi and Dr. Scott Shreves, Scott's the CEO here, we just believed in primary care. We felt like the healthcare system was great at being firemen and racing to the emergency. And we just were constantly doing the emergency thing. And Scott was an emergency medicine physician. And we just had to pivot that. We weren't getting ahead. We had to find a way to insert primary care foundationally. And so that has been really important to us. And it's not just to hang the shingle up and do primary care, but it's actually get to that next level of what are the behaviors of the people that we're delivering care to that impacts their life, right? I mean, it's not just about managing a diabetic with the right medications and the right courses, but it's like what's happening in their world, in their job, in their families, in these other social factors that prevent them from being able to obtain that steady state of health. And so that became the foundation of what Crossover was doing. The challenge, Molly, is that if you want to do that in healthcare today, and you're like most people, you're going to do it getting paid fee for service. But when somebody calls us and they have issues with a flat tire or transportation, or we're dealing with these other issues that don't have an ICD-10 code associated with it, you can't charge for that. And so we felt like there was this misalignment with that, and we had to go someplace to find a different way of getting paid. And so that was really the foundation of how Crossover started. And what we've tried to maintain is focus on the member and then pursue those alternative payment models where we could protect the provider's time to build relationship, right? And see people get better. So we're doing a lot less firefighting. Let me just say one other thing, and I'm looking forward to hearing Nina and Rebecca respond, but there's a great book, Implementing High Quality Primary Care. Hopefully the people on this phone are evangelists for this. This is the NASM study. I've got a gazillion copies. Rebecca's smiling. Oh, yes, there. Nina. Yes. But there is a quote in that book that I just have to cite, and I hope this sinks in. It's on page 4. Nina has it memorized just like me. But it says, primary care is the only healthcare component where an increased supply is associated with better population health and more equitable outcomes. And honestly, I think we all believe that, but it's just a really small speed bump, quote, on a really fast highway, and it just gets run over all the time. And hopefully that's something that we can elevate and appreciate of how important primary care is to our healthcare system.
I want to say one thing too about what primary care. I agree with everything you said, Nate, and Molly. Your really well-written intro, would echo all of that. I want to say when I think about primary care too, I think this is important. What's included in that, and how broad is that model? And advanced primary care models, I think there is starting to be real consensus that it includes behavioral health, it includes navigation. Really good asynchronous messaging, possibly some other specialist services. And I think that's really important when you think about what people need to foundationally take care of themselves and stay healthy. It is broader than a lot of times what is under primary care, and it's certainly broader than necessarily the preventive services that are free under, again, under HDHP plans, especially because many times if someone goes for preventative services, it actually becomes diagnostic, more than half the time, and then there is a charge. So again, coming to those affordability, access, navigation, just patient experience reasons, looking at ways to, strengthen primary care and really good primary care, and having that help to navigate the rest of the care and the cost of that care.
Mm-hmm.
Nina, you were previously medical director for a primary care group. You are a primary care physician. What have we missed? Is there anything you'd add?
Well, I was a medical director of primary care for a multi-specialty medical group. So I think, and I'm making the distinction because I think I've really existed in that world where it is not just an exclusive primary care model. And how do you, historically, primary care has been very sidelined in that model. It's like maybe the loss leader. Health systems have primary care practices because they bring in lots of patients for their specialists and their diagnostic imaging and such to make money. And I always believed in my heart, I went into primary care in the 90s when everybody was trashing primary care. So I always knew, like in my heart, that it was the right thing, but it's been magical to watch the perspective of the health systems change over those years, those decades, to center primary care more. Blue Shield of California is a state health plan, not-for-profit health plan, and we're very invested in the idea of creating a healthcare system that is worthy of our family and friends. Like, we really try to ground ourselves in who are our neighbors and how can we make this work better for all Californians. We think about that a lot, and then we add on to that, and it has to be sustainably affordable. And when Blue Shield looked at that, mission statement, which we don't just like write, put on our website, we really think about it day in and day out. We thought, like, what's going to do that? What's going to make a healthcare system worthy of our family and friends and sustainably affordable? And like, there it was, primary care. We have to figure out how to invest in primary care. And so we thought, like, okay, what are the usual levers that we can use to invest? We can increase the fee-for-service rates. We can, dump money into practice transformation. And we thought, maybe there's a different way that we could go about this. What if we increased rates by creating an alternative payment model and getting primary care to think differently about the way that they can make money from us? And so when we thought about it that way, it really became primary care reimagined, like using payment to shift the way people deliver and think about and receive care in the primary care setting, and using that to drive change for the whole healthcare system. That if primary care can really deliver on value by being paid on value, they can start to push and influence the whole healthcare system in that direction. So it's been a really exciting journey. It started before the pandemic. We put out a PPO value-based payment model during the pandemic with the idea of really investing in these small independent primary care practices that were failing, giving them money up front that could sustain their businesses. And we're now rolling that out throughout the state to not just small independent practices, but large systems, and starting to see how that's influencing change.
I mean, this conversation really resonates with me, and one of the key ingredients that we've seen to go to back to this payment piece that you all have touched on is really being able to find the right local market dynamics to build and invest in primary care, and do it through alternative payment models. We think that like-minded partnerships are important to do that kind of work, but also, taking on risk requires additional demands on provider practices, investments in staff, care management, data, technology. And so having those right partners at the table to do this work together is critical. We are doing this for our own JP Morgan Chase employees. I mentioned that earlier. We're doing it in Columbus, Ohio, where we are bringing together one of our portfolio companies that we've invested in, Apri, which has an advanced primary care model through Vera Whole Health. And they are working with Central Ohio Primary Care, COPC, and we're bringing them together at our on-site and near-site clinics of our offices for our employees. And Apri is not only bringing the sort of the coaching and the behavioral health, so Rebecca, to your point about sort of what do we think of as primary care, but also wellness. to really not only provide that integrated care to our employees, but also to help build out a customer-focused journey that is enabled and backed with technology, and to support providers in taking on total cost of care incentives for value-based payment. And so I'm curious what your experiences have been when you think about the right types of environments to pursue these sorts of partnerships. Are there certain conditions in local markets that are needed to be able to get a foothold and then generate momentum around these alternative payment models?
I think it's a really interesting question. One of the issues with value-based payment in primary care is that little independent primary care practices can't take on full risk for a population. You need to have enough of a bulk of patients to be able to absorb the risk of an expensive patient who has a bad year, and so you need some degree of consolidation in order to build a model where people can take full risk. And then along with that, you also need partnership, because it is a shift and a change. And so you need people who are willing to experiment to some degree with how payments work, to tolerate bumps as you make the changes and work them through, because interestingly, they require these basic changes with payment systems, with claims processing, all these really supposedly boring issues that essentially drive accuracy of payments, which drives trust between payers and providers, which then drives the willingness to continue to work on change. So we started out with small independent practices just going all over the state of California, fanning out and negotiating new contracts with providers who might take care of 80 or 100 of patients in their panel. And now we're really working out, like, okay, when you take that little practice and move to larger systems, how does that start to look? What different issues start to come up?
And Nina, I've got a question. When you work with them, what is the payment structure? Is it the alternative payment structure with them? Because I think one of the challenges that exists out there is, from a small practice, is like the viability of that practice. I mean, these are not lucrative practices, and so a change in their payment model, it represents significant risk. And I think you addressed that a little bit with some prepayment or some lump sum payments in the beginning to help them in that transition. But I think this is probably one of the scariest things for a practice where you've got some fee for service coming in the door, maybe a little bit capitation, and then you kind of know what that predictable revenue stream is, and then changing that to some other alternative payment model where you don't have experience on what you're going to get. So how does that work for those small practices?
Yeah, it's true that the devil is really in all those details. One of the things that was reassuring is that we had years of claims data going back on these practices, so we could really do a comparison run of their claims through the new model and through the old model and show them that there was stability of their income. Like, they would be able to guess, if they just kept practicing exactly the same way that they would really, reasonably be able to predict what they would make. And in fact, that it would be more stable because of the population-based payments that were part of the new payment model. And then the exciting thing was that the investment piece was like, we could show them with data, here's your data on your quality performance, here's your data on your risk adjustment. As they started to be able to tinker with how to do better on those two aspects, they could see a way to make more money, essentially raising their own rates, right? But just doing it not through a negotiated increase in fee-for-service rates, but through an improvement in their performance. So I do think that the trust and the years of experience with a brand new practice, it would have been really hard to guess how they were going to do on a model like this.
That's super helpful for us, Molly. It's really high risk. So today, again, as I shared before, we work with large self-funded employers, and they pay us directly. There's no payer intermediary, and so we were progressing down that path. But again, when we started Crossover, it wasn't like we were saying, hey, let's go serve these super large self-funded employers. We wanted to, disrupt primary care across lots of different segments. It just happened that those were the ones that could pay us that fixed fee arrangement and that non-fee-for-service approach that allowed our doctors to have their panel sizes the right way and to be able to deliver on those quality outcomes and spend time on the social determinants of health topics with our patients. The challenge is like, how do we get to that next level? And so if we go into a market, right, and we open a health center, we're not accepting any fee for service at all, right? We're not jumping on that. And so it's hard to go from zero to a level where you can, pay your rent without having a good startup plan. And, Rebecca referenced it, we started this approach. We launched it with Aetna in just Seattle, right? Certainly state laws matter a lot. And the thing that we had worked out with Aetna is that they would pay us a fixed fee amount per member that attributed to us, right? And so there's no fee for service billing, period. That gave us the protection for our providers. Now, it's still a big risk for us because we got to get to that membership level. But it allowed us to enter the commercial space where any Aetna member could walk in the door, and our doctors didn't have to worry about the fee for service because they knew they were going to be getting that payment structure and a fixed fee model that protected their ability to deliver on those principles of advanced primary care that were part of our core philosophy. And so that, to me, is the hardest thing, is finding ways to build relationships with payers where in their claim system they can do those fixed fee payments, right? There certainly are state laws that play into this, and California, New York, and other states have pretty complex state laws. I won't say hard, or they're just complex, right? And so you have to understand them well to make sure that that you're living within those. But I think from our perspective, the markets matter a lot, but it's also those payer relationships. Nina mentioned it, building trust, but also just the mechanics of not getting any sort of fee for service matters a ton for us to be able to continue to deliver on our model.
Rebecca, I'm curious from the payer perspective, when you looked at, when you think about partners, when you started to explore this with Crossover, what were the things that you all were looking for in deciding who the right organizations were to partner with?
Yeah, when we were vetting providers, one of those first criteria was we were looking for someone who didn't have the fee for service infrastructure. We were really looking for that fixed direct primary care type model. I think working through this with Crossover has really been a partnership process of figuring out what's going to work, and a lot of iteration, because there is a lot that needs to be worked out, all of those boring administrative type things that Nina, you mentioned. There's a lot there, right? You can't just there's a lot of IT that you've got to do, and so just working through that, because we're still this is still more nascent in commercial, all of these kinds of models. And so I think there is a kind of relationship that payers and providers need to find with each other, where you have the same vision and North Star, and you're just going to keep problem solving until you figure it out together. But it did come down to really actuarial work, I would say, in terms of vetting for Crossover and other providers that we looked at. Like I was saying at the beginning, we're really looking for this to be something that improves access and affordability, has $0 cost share, but we're not looking to increase costs for our employers. And so really looking at the data behind the provider, what they can do in terms of costs, and how that works actuarially. We spent a very, very, very long time with our actuaries and with our analytics folks, because we're putting our money where our mouth is. We're doing this fully insured as well as self-insured for employers. And so obviously we're going to be careful about doing that. And I'm very excited that we've gotten to that point of confidence around fully insured, because that, we should be able to do it with ourselves if we want to do it with our self-insured customers.
The other partner, Nate, that you talked about was employers. And as you can imagine, a lot of the work that we're doing at Morgan Health, when we think about piloting and offering new options to our own JP Morgan Chase employees, we're doing that in partnership with our benefits organization. I'm wondering if for crossover, you talked a little bit about this, but are there certain types of employers that are ideal for you to work with? And can you just really distill for the group, what is it that a partnership with a crossover can do that these organizations aren't able to do on their own today?
You mean the employer organizations, or what organizations specifically?
The employer. Yeah. So if I'm an employer and I'm working with crossover, what does that look like? And also from your perspective, who are the ideal employers to be working with, whether that's sort of size, goals, mission?
Yeah, I think that we profile lots of employers, financial, media, tech, distribution companies, retail. I mean, any employer could fit it if they have a passion for serving their members. If that's probably in their mission statements, that's where we find it. And so we've had the benefit of working with a variety of employers across all industries. They participate in groups like PBGH, Purchasers Business Group on Health. They're spending a lot of time. National Business Group on Health. There's lots of organizations. ANDS Group, right? We're starting to see more commercial entities join ANDS Group. So those that are participating and following along, and I think even crossover, we're a self-funded employer, you just get tired of paying more for healthcare, and you're like, what are we doing? Like, how are we solving this? And so I think those are some of the characteristics that we see. I think from an employer perspective, what they can't do is deliver care, right? I think that we're a primary care entity, and they look to us to come in and set up that foundational model. One of the things that I learned along the way is that when I would talk to an employer, the problems they were trying to solve is like, they have no access for their members. Like, they can't get in less than 30 days, right? The experience isn't great. The affordability is challenging. The productivity isn't there, right? And so these are some of the things that they were thinking about and trying to solve. And so we would go in and we would build a primary care center. Some of these 2,000 or 3,000 square feet, some 20,000 square feet on employer campuses. So a big variety. We do on-sites and near sites and virtual. But one of the things that was interesting along the way is just doing the advanced primary care is really good. And so people would come in, Molly, and we would deliver an awesome experience. But then we started to notice a cohort of those members utilizing these centers on employer campuses or near campuses. And we said, if they're highly engaged in primary care, they act very similar. They listen to the doctor. They're super compliant with all of the follow-up. They're engaged in health coaching. They go to the specialist that we refer out. And it's almost like what we started to realize is like there needs to be a plan design around this. And that's one of the things that Rebecca, that's really when I started to talk to Rebecca, is we said, look, I think employers are looking for those high quality foundational primary care experiences. But one of the things that really emphasizes that primary care is a plan design that caters to that. I think one of the things that employers are starting to recognize, I think it's ironic, is that over the last 10 years, primary care is like the hot topic. I mean, you see it on CNN articles, you see it in the Wall Street Journal, you see it all over the place. Ironically, over that same period of time, in this book quotes it, there's like a 30% decline in primary care use. And so what's going on? What's at the core of that when everybody out there says primary care is the best thing ever, yet consumers are actually utilizing it less? And that's where I think that employers in their unique entity can elevate primary care through their plan design, working with TPAs or ASOs to really make sure that primary care is foundational. Because if it's just another node in that whole massive network, then I think that we're not really doing something different, right? We really want to make it foundational. Again, there's the Commonwealth Fund publishes annual surveys on this, and they point out how other countries are better than us and with healthcare. And one of the common things is just how they have a foundational primary care. It may not be the experience that we have, but everything seems to start with primary care. And I think that's what employers are looking to organize for their employees.
Yeah, and I think the thing we think about, and Rebecca, I'm curious what you think about this. You mentioned like fully insured products and how you feel now comfortable moving to this sort of approach in a fully insured product. But it's one thing to have a giant employer that can afford to be self-funded to offer the right kind of care to their employees. But like, what about a small school district? Why shouldn't those teachers and their families get the same kind of care? And so as a network insurance company, we feel like, oh, we have to figure out how to take this privilege essentially of access and the right kind of care, personalized, longitudinal, comprehensive, and make that available to affordable, right? Like that any employer could buy that plan and take it out of the sort of 5% and make it available to most people. And so that's what we're really trying to crack with, if we resource all of primary care in a different way, resource, I mean pay, then do they become more capable of taking on that kind of risk? And then, can we drop the prices in the healthcare system enough that we can price our plans at a level that become affordable for everybody to be able to buy, all of our friends and family?
Yeah. To answer your question, Nina, so a lot of what I've worked on is advanced primary care as an additional benefit. So it's additional to our existing network and so forth. And so for fully insured, we can just turn that on for companies, for plan sponsors. And so that affects all kinds of sizes. You don't have to be, a giant company who can afford that. And so the exciting idea is that you're democratizing, like you're saying, access to these kinds of models. And then for self-insured plan sponsors, they can opt in to add that benefit as well. And so, the plan design aspect that lets you have a benefit differential where this care can be $0 and really helps people stay in the model has been really important to how we've been thinking about this. Having these things in the network, I think is good too, but you get that extra bonus when it is a benefit because you can have it. You can really control, like it can just be free. You can remove those micro barriers, like my behavioral economics, showing. I just want to remove all of those micro barriers to people acting the way that we would like them to be acting. Even if you can afford, whatever you think it's going to be, psychologically, it's still a barrier a lot of the time, perhaps, or not knowing what something is going to cost is also a barrier, even if it technically is something you could afford. So just removing all of those sources of friction.
One thing I want to say, just on Nina, on your comment, I've gone to all the payers, right? I've talked to a lot of them, and it's hard. And I'm excited to be talking to Blue Shield of California. One of the things from a medical group's perspective is when I go to those payers, they all have value-based programs, right? And then they put me in contact with the value-based leader, and they're like, yeah, we do value-based, And it's 95% fee-for-service with a little bit of payment on it. And that's the struggle. And then when I push them and prod them, their claim system can't administer a non-fee-for-service value-based model. So at the end of the day, we call it value-based, but it's all fee-for-service. And you are 100% right. And this was really our ambition at Crossovers. Like, we didn't sign up to just serve the self-funded. We signed up to serve everyone, but it's so hard to serve the everyone else when you have to step in and compromise your model and get on that hamster wheel again to say, hey, look, I want to serve that small group that has not great access. And that's where I hope that the models like what we've been able to explore with Aetna expand into being able to get into that commercial population and serve others.
Nina, I'm curious if you have any comments in response there. I also have a question. We have some Q&A from the audience. I'm curious about your thoughts on this one. Are these self-insured alternative payment models appropriate for pediatric patients as well? And how do you think about that?
So I think that you have to be careful with self-insured payment models because I think they're very differently regulated state by state. I know in California, there's very significant restrictions around payment models in the self-insured, around population payment models in the self-insured space, because essentially it's passing risk on to the provider by the employer. So there's a lot of regulation around it in California. I can't speak to other states. But in pediatrics, it's a really interesting question in pediatrics, I think. We, in our alternative payment model in primary care in Blue Shield, we actually do have a separate model, I mean, the same model, but separate metrics for pediatrics versus people who take care of all adults or some adults and some kids. And it's harder in peds. We have a hybrid model, which is what's recommended in that National Academy of Science book that Nate held up. So we have a hybrid model. Some of our stuff is paid fee for service, some is paid under population or PMPM payments. And in pediatrics, more is paid fee for service than is paid in the PMPM because of the nature of peds. We wanted to incentivize volume on wellness visits, and pediatricians do tons and tons of wellness visits disproportionately to their sick visits. So that's different. I do think though, and this is the last thing I'll say, I think we need better metrics in peds. We have very few quality metrics in peds, immunizations, weight counseling. And I think that it's a good time in the history of medicine for pediatricians or people who take care of kids to work with quality rating agencies to come up with metrics that better describe the work that's done by those doctors who take care of kids.
I think a question related to thinking about different populations. One thing that's really important to the work that we do at Morgan Health is a focus on health equity. I said that a couple of times, I think, when I was introducing our organization. For those who may be curious if, they're working in the commercial space and wondering where health equity fits into that, Morgan Health issued a report with NORC out of Chicago a year ago where we looked at across the employer-sponsored insurance population, are there disparities? And surprising to some, perhaps unsurprising to others, we see disparities across maternal care, across behavioral health, across chronic conditions. Curious, and we only have about 10 minutes left, and there may be some other audience questions coming in, but can you each give any examples of work that you're doing where you have seen a real impact as it relates to health equity?
I mean, I've seen, people talk about the greater access they got, saying, I never felt like I could afford behavioral health or physical therapy, and now I can, and wow, I've needed this for years. So, I mean, that kind of thing I think is really powerful, and employers want to increase that kind of access. They just need to do it in a way that's also fiscally responsible for their budget and their needs. And so finding that way to make that win-win situation is what was, really meaningful.
Yeah. Well, one of the things that really surprised me when I arrived at Blue Shield, I thought that the insurers were sitting on piles of information and data that they weren't sharing with us as providers. And then I got here and I discovered, for example, we don't have anything near comprehensive race, ethnicity, and language data or SOGI data on our members. We don't have it. It's completely voluntary, and we don't do a good job of collecting it. So one of the things that we're trying to do is improve that data that we have about our membership. Who are our members? And we're doing some interesting things, like using the California Immunization Registry data, which includes race and ethnicity and is publicly available, and we're importing that into our data about our members. So instead of using imputed data, we're using actual self-reported data. But I don't want to dodge the question of just saying like, oh, if we just had the data, we would be fine, because I know that's not true. Having the data allows you to see how terrible things still are. And so we've looked at alternative payment models, for example, paying differentially for care gap closure in historically disadvantaged populations where the population was at a disproportionate effect in the disease or disproportionately underscreened. And we found out that regulatorily we can't pay disproportionately. The same laws that were put in to protect people from racial discrimination actually prevent you in some cases from paying differentially. So we're trying to explore, like, well, are there ways that we could look at equity in people's and pay differentially on their equity score? Like, if they have less disparity among populations, could we award as a quality bonus in some of our alternative payment models? So we're continuing to explore not just how do we get better data, because that is important, but how can we use that data to actually push people to see what they're doing and then reward them for doing a better job.
And Molly, I'll say, this is a complex topic and it's a super important topic, and there's some of the aspects of health equity are going to take a long time related to education and fair education to make sure that we're educating providers to be in communities to serve better, right? One of the things that's really sensitive to us is affordability. Healthcare is still very unaffordable, and I think the prevalence of high deductible health plans makes it even more unaffordable. I was at a client site. They spent a bunch of money, and their workers were probably $15 an hour workers. I remember a woman came up to me and she said she was curious. I explained it to her. She's like, "I need mental health," and I said, "Absolutely." And because of the high deductible health plan, we had set it at the fair market value, like 100% of Medicare, which might have been like $35, $40 for her. I said, "Hey, it's going to be a $40 visit for you to access the mental health," and she says, "Hey, let me come back after my next paycheck." And I'm thinking and doing the math, that's like 4 hours of after-tax dollars for her to be able to afford a mental health appointment. Some of these health equity topics are easier to fix than others. The one that Nina explained, those are some of the harder ones, I think, and I think they're really important. And payers have a strength to solve some, providers have a strength to solve others, but we've got to be coming at this from all angles. And I'm particularly sensitive to the affordability side, and that comes into a plan design play where, making access to foundational primary care low cost or $0 would go a long way of just addressing fair access and affordability for many Americans.
Yeah, I know that we only have a couple of minutes left, and I feel like there's so much that we haven't even touched on yet. I'm going to try and combine a couple of questions, and then we'll do some sort of closing thoughts. But Nate, you're touching on this sort of supply-demand access equation. And a question that we received is, how has the acquisition of primary care groups by health plans and private equity changed the landscape for alternative payment models? I think a related question, we are all reading in the news, there is a provider shortage in this country, and yet we're trying to deploy models where providers can spend more time with their patients as they should. How do you think about both sides of those equations? And Nina, maybe a question for you here. Would love your thoughts on this. And also, I think, are these types of models better for doctors? Like, what's the doctor perspective on this?
Yeah, I mean, I'm just an opinion. Sorry, Nina, I'm just an opinion. I don't have a great opinion. I think that, I think that we're approaching a state where we're fearful of the supply of doctors. It hasn't impacted our business. I think with large payers buying up primary care doctors, the big question is, what are they going to do with it? Are they going to secure those providers to continue the existing model, or is there a massive change that'll come that will push us towards foundational primary care? And again, in this country, it will require dozens of great entities to come together to build a fabric of foundational primary care from coast to coast. And so I think I'm hopeful that payers act in a way that own primary care doctors. Optum is like the biggest employer of primary care doctors, I think I heard. But what are they doing with that? And is it improving, or is it just protecting the base to continue to do the same thing of firefighting, which is driving up healthcare costs? So I don't know what's going to happen. I'm curious to see how they deploy those providers in a better way.
In answer to your question about whether these models are better for doctors, primary care doctors, I would say they have to be. But I would also say that they're not necessarily. You can build them to be absolutely horrible. And you can build an alternative payment model that gigantically increases the administrative burden on a doctor with tons of new coding regulations and, stresses them out and makes them just want to pull every hair off of their head. So I think you have to think really carefully about that and listen and be willing to be flexible and change as you work through, what a new alternative payment model is. I will say though, the thing that really got me started on this pathway way back is that I just like randomly had the opportunity to participate in a patient-centered medical home pilot back in 2012. And I can say unequivocally, that was in my clinic, right? Like there were like 12 of us clinicians, doctors, nurse practitioners, and PAs, and we got to shift over to a PCMH model. And I know there's problems with PCMH, it's not perfect, but we went on salary, we got a nurse case manager, we got a pharmacist, and we got trained in lean process improvement. And so we all started to work together differently, looking at the problems together, trying to see that elephant from all of the perspectives as the people in the system. And it was unequivocally better for doctors. We were so much happier. It shifted the way we thought about our practice. Those of us who lived through it, I think, have been permanently changed by it in terms of the way we look at delivering primary care, our belief in it, and just that relationship that we could build with our patients. And I will say that I think that bringing in those different team members does allow one primary care doctor to take care of more patients. So while it's not alone going to solve the clinician shortage, I do think some of it is going to be shifting people from specialty into primary care, because primary care is going to be so awesome in this new world. I do think that enlarging of the panel, because you're not just doing your work in the visit, becomes a way that we can expand access to primary care, even while we're lengthening the visits.
Nina, what a great note to end on. I think we can all safely say primary care is it's having its moment. Companies like Crossover are reimagining what that can look like, and I love how much we spent time today talking about the importance of finding the right partners to do this work, invest in primary care, take on risk together if we're going to be successful in these models. I want to thank you all for a great discussion. As a reminder for the audience, this webinar recording will be available in a few days on the PCC website. And thank you all for joining us today.
You're welcome. Thanks for having us.
Thanks so much.
Thank you.